So, hello and good evening, everyone. Can you please let me know in the comment section, the chat box, if my audio and video is good? So I'm just waiting for your message so that I can just start. Okay, so this will be a very quick, rapid fire discussion of the questions of the third Monday midday quiz that we conducted, and the topic was stroke. So if anyone is viewing this in YouTube who has not taken the test, so please understand that every Monday we'll be conducting a very short and sweet quiz of medicine in the DocTutorials app. Just 10 questions to be answered in 5 minutes, and the winner gets a very good prize as well of a Littmann stethoscope. So do take the test every Monday. We'll be having, topic quizzes. These are short quizzes, so please do take the quiz. So good evening, Mithilesh, Vikas, Sayak, Rose. Yeah, good evening. Right. So let's start. It's, as I told you, it's a very quick, short, sweet discussion. Okay, I'm not going to go too much to the details, just a very concise discussion of the 10 questions asked in the quiz. Okay, right. Let's move forward. Okay. Now, the first question for the quiz was, which of the following clinical factors is weighted most heavily while calculating the ABCD2 score? ABCD2 score is very important topic. Remember, this score is used for the prognostication of transient ischemic attack. If in MCQ they give one option as diagnosis of TIA and another option as prognostication of TIA, answer is prognostication of TIA. Okay, it's not for diagnosis of transient ischemic attack. If a patient develops transient ischemic attack, the probability that he develops stroke, a stroke in the coming few days or weeks, that risk is assessed by the ABCD2 score. Now, they have asked what is weighted most heavily. So let us, have a look at the ABCD2 score and the parameters. A quick look at the parameters will tell you that A is for age more than or equal to 60 years. B, systolic blood pressure more than 140 or diastolic blood pressure more than 90. C, for clinical symptoms. If the patient has unilateral weakness, 2 points. If the patient has just a speech disturbance without weakness, it is 1 point. Okay, now let me ask you a question in the chat box. Suppose you have got a patient who has both weakness and speech disturbance. What is the score that you will assign? Please answer in the comment section. And D is for duration, more than 60 minutes, 2 score, 10 to 59 minutes, score of 1. And if the TIA is lasting less than 10 minutes, you'll put a score of 0. And the second D, because it is ABCD2, so there are 2 Ds into it. So the second D is diabetes, which is given a score of 1. So let me just check. Okay, somebody is saying 2, Sayak, Gagan, absolutely right. Even if the patient is having a combination of weakness and speech disturbance, you will not give it 2 plus 1, 3. It's only the maximum score that is actually taken into consideration. Understood? Yes. Now look at the options. Age more than or equal to 60 years, blood pressure, diabetes mellitus, all it is 1 point or 1 score, but unilateral weakness is weighted more heavily. Okay, so that is why this is going to be the answer. Option D is going to be the answer, unilateral weakness. Okay, so I hope that is very clear about ABCD2 score. Okay, so what is the maximum score? 1, 2, 4, 6, 7, right? The score, maximum score is 7 that can happen, right? Okay. Now let us look at the second question. I hope the first question is very clear for you. Second question, 53-year-old man presents with acute onset weakness of right upper and lower limbs along with headache and vomiting. So the CT brain, if you look, you can see that in the left side. So this is a non-contrast CT brain axial section. And in the region of the basal ganglia and the internal capsule, you can see a very well-defined hypodensity. So what is this hypodensity? Is likely to be a intracranial bleed, and intraparenchymal bleed. Now they have asked, what is the likely etiology? See, what is the etiology based on the imaging and clinical features? It is definitely an intraparenchymal hemorrhage. And if you take into consideration the location of the hemorrhage that is in the basal ganglia region, you know that hypertensive intracerebral hemorrhages are very commonly known to involve the region of basal ganglia. If they are asking you which region of basal ganglia, to be more specific, what is the answer? Putamen. If they ask you what are the other sites of intracerebral hemorrhage, what is the answer? Other than putamen, thalamus, cerebellum, pons, and even you can have the involvement of the cortical region as well. So this is the typical location of a hypertensive bleed. Now option A, cerebral venous thrombosis, it presents more like infarct. Cerebral venous thrombosis is a venous stroke. It presents like an infarct, but can it have a bleed? Yes, there can be a hemorrhagic transformation of the venous infarct. But remember, in case of an infarct or a hemorrhagic transformation occurring in a CVT, how will you identify? It will not obey any vascular territory. If there is an artery being involved and there is an infarct or a bleed, the bleed or the infarct will be in a particular distribution of the vascular territory. You will suspect a venous stroke when there is an atypical distribution. You look at the imaging and you feel that, oh, the infarct or the bleed is not obeying a definite territory. That is when you will think of cerebral venous thrombosis. Okay, atrial fibrillation, we know it can predispose to, again, cardioembolic stroke, which again, you know, it again can present as an infarct, which may undergo a hemorrhagic transformation. Amyloid angiopathy, this is not the classical location of the bleed in amyloid angiopathy, and we'll be discussing a similar question shortly. Okay, so what is the answer here? Answer is the second question. Answer is option C. Let's quickly go to the next question. Third question is a MCQ that is integrating medicine as well as radiology and a bit of anatomy also, I should say, right? So all the following are features of anterior choroidal artery territory stroke except. So you've got to be aware of your anatomy here. So hemiparesis, hemisensory loss, homonymous hemianopia, and the last option is predominant involvement of the anterior limb of internal capsule. So if you look at the vascular distribution of the cerebral hemisphere, if you look at the blood supply to various parts of the brain, you can see that the distribution of the anterior choroidal artery. I want all my children to focus on this particular area, that is the distribution of the anterior choroidal artery. Did you see this? This is the distribution of the anterior choroidal artery. Now, this is almost like a sandwich area. You can see that between the ACA territory, MCA territory, and the PCA territory, a sandwiched area is the region of anterior choroidal artery territory. And keep in mind an important MCQ point. A stroke in the distribution of anterior choroidal artery is very similar in clinical manifestations to a lenticulostriate artery stroke. A lenticulostriate artery stroke, which is the deep branch of the middle cerebral artery. Infarct, okay, when there is an infarct involving the deep branches of MCA, which is the lenticulostriate, can produce a contralateral hemiplegia, contralateral hemisensory loss, and contralateral homonymous hemianopia, and exactly the same features can occur with an anterior choroidal artery stroke. But all my dear children, if you look at the image here, you tell me the anterior choroidal artery is, is actually supplying anterior limb of internal capsule or posterior limb of internal capsule. It is posterior limb of internal capsule. You know that the internal capsule has an anterior limb, a genu, a posterior limb, and a retrolentiform and sublentiform part. Okay, so remember the problem about option D is that it is not the anterior limb that is involved, it is the posterior limb that is involved. Option A, B, and C are in fact, manifestations of anterior choroidal artery territory stroke. So answer is option D. Perfect. Let's go to the next one. Once again, let me remind you, this is a very quick rapid fire discussion of the questions that we conducted in the midday quiz in DocTutorials app. Not a very elaborate one, but I want to keep it short and sweet so that you gain maximum information in a short span of time. Next question is based on the CT brain finding shown. What is the neurological deficit in this patient who presented with acute stroke? Is it Wernicke's aphasia, left homonymous hemianopia, right lower limb weakness, and none of this? What do you think? Roshan, Ramesh, Abha, Lakshmi, Venu, what do you think is the answer? Mithilesh? See, I just wanted to see after this exam as well, how many of you got full scores? And I was happy to see, I saw Pranath Mishra, I saw Indrakni, Anirudh, all getting top scores. And I was happy because, sometimes when you get a question like this, you have a tendency to mark any of the options A, B, C. But those who have got full mark, they have confidently marked option D. That is none of this, which is good. As I see here, Trinath, Anirudh, Indrakni, Hanan, Keshav, Girish. So 6 students have got full score, 10 out of 10. Congratulations to all of you. Very well done. And the winner, I think I'll have to decide based on time. I think Trinath Mishra has answered it in the shortest span of time and is the winner for this quiz as well. Now, Wernicke's aphasia, is it correct or wrong? Is it correct or not? Okay, so yes, as somebody is correctly pointing out, Sayak, it is a right anterior cerebral artery stroke. So you can see that the hypodensity is in the distribution of which vascular territory? Anterior cerebral artery. You can see here, this is the ACA territory, correct? And is it left ACA or right ACA as per the CT scan? It is the right ACA territory, understood. So it is a right ACA territory stroke, understood, perfect. So it is not going to be a Wernicke's aphasia because Wernicke's aphasia happens in usually dominant hemisphere strokes and it is due to a middle cerebral artery affection. And it is usually, you've got the superior division of MCA, inferior division of MCA, inferior division of MCA is affected. Homonymous hemianopia is unlikely to be a finding that happens with an ACA territory stroke. It is a less likely finding. It is usually seen with MCA territory strokes. Right lower limb weakness. Well, you can have a lower limb weakness, but remember, when you get a right ACA stroke, you are going to get a left lower limb weakness and not a right lower limb weakness. Can you just tell me how many of you got fooled by that option? Okay, you can answer in the comment section. So it is going to be option D, none of this. Okay, right. Option D, none of this. Right. Question number 5, the definitive treatment for a patient with acute onset left hemiplegia with CT angiogram showing right intracranial ICA and proximal MCA, that is MCA matlab middle cerebral artery thrombotic occlusion presenting at 5 hours of onset of stroke. See, what you should understand is this is a case of acute stroke. Patient is having a hemiplegia and you can see the angiogram is showing occlusion of which blood vessel? The intracranial internal carotid artery and the proximal part of middle cerebral artery. Now, what does that mean? It means that there is an evidence of LVO. Can someone tell me, based on my lectures, I commonly use this LVO terminology in my lectures. Can you tell me what is LVO? LVO means large vessel occlusion. Okay, large vessel occlusion. Large vessel occlusion. So when you get a large vessel occlusion at 5 hours of onset, which means that a patient presenting with a large vessel occlusion within the first 6 hours of onset of stroke is definitely a candidate for mechanical thrombectomy. Can I go for an IV thrombolysis here? No, because IV thrombolysis is only up to 4.5 hours. Aspirin alone, aspirin plus clopidogrel, see, definitely they'll be used in the treatment. But the question is regarding the definitive treatment. In this patient, there is a possibility that you can do a revascularization, which means you can remove the clot inside the blood vessel. So what is that procedure known as? It is known as endovascular thrombectomy or mechanical thrombectomy. So the answer is going to be option D, mechanical thrombectomy because of the large vessel occlusion. Perfect? Fine. Right. Question number 6, during a neurological examination, you ask a patient to stand with both arms fully extended and parallel to the ground with eyes closed for 10 seconds. What is the name of the test? So this test is referred to as the Pronator Drift. It is also referred to as the Barry's sign. Okay, I have taught you this in my lectures, pronator drift. So remember, what is the utility of the pronator drift test? It is used for detecting any subtle weakness of upper limbs. See, if you have a patient with severe weakness of one side of the body, is there any use of doing this pronator drift? There is no use. There is no use of demonstrating this Barry sign. It's only when the patient has subtle weakness and you've got a doubt, I think there is a weakness, that is when you will do this test. So as I have written in this slide, the individual is asked to stand with both arms fully extended and parallel to the floor while closing his or her eyes. If the arms flex at the elbows or fingers, or there is a pronation of the forearm, it goes down, that is considered to be a positive test. So what happens is that when there is a UMN lesion, the supinator muscles in the upper limb is weaker than the pronator muscles. Okay, so the pronator will actually take the upper hand in a UMN lesion, which is why the arm will drift downwards and the palm will turn towards the floor. That is exactly what you're seeing in the image. Look at image 1, that is the starting position, and you can see that the left upper limb is drifting down. That is called pronator drift. Babinski's sign is the extensor plantar response, so that is not the answer. Dysdiadochokinesia is the inability to perform rapid alternating movements, which is a feature of cerebellar lesions. Lermite symptoms refers to the electric shock-like pain radiating from the neck down the back, which is usually seen in case of multiple sclerosis as well as any sort of a cervical spondylosis. So that is also not the answer. Or its answer is option D, pronator drift. Okay, good. Right. So that is also over. Okay. Next question number 7, duration of dual antiplatelets after a transient ischemic attack. What is the answer here? See, remember, transient ischemic attack is an opportunity. Opportunity for what? To prevent a recurrent stroke. And the recurrence of stroke following a transient ischemic attack is maximum during the initial few weeks. So in the initial few weeks, you will have to be aggressive. So following a transient ischemic attack, for the first 3 weeks, remember, for the first 3 weeks, you will give the patient dual antiplatelet to give an extra protection against a further stroke. And following that, following 3 weeks, you can go for a single antiplatelet lifelong. So 3 weeks aspirin plus clopidogrel, then followed by aspirin lifelong. Okay, that is option C. Okay, right. Then question number 8, 85-year-old man presented with headache and left-sided weakness. Non-contrast CT showed right frontal lobar intracerebral hemorrhage. Results from the CT angiography of the brain were normal. The patient takes warfarin for atrial fibrillation and his INR was 1.4. His medical history is notable for well-controlled hypertension and he also has dementia. What is the most likely cause of hemorrhage? I've always told my students, when you get a long, lengthy STEM clinical scenario question, the first thing you have got to do is to read the last line first. And they've asked you about, again, the cause of the hemorrhage. Now, I just want you to look back at the other question that I asked you today on another question asking you about the likely etiology of the bleed. Now, here also, they are asking you about the likely etiology. Now, let's have a look at this. See, patient is having headache and weakness. There is a lobar bleed. Now, this is very important. The pattern of bleed is in one lobe. It is a right frontal lobar intracerebral hemorrhage. Okay. Now, can a lobar bleed occur because of hypertension? Possible, but less likely. I'm repeating it. Possible, but less likely. Results from CT angiography of the brain is normal. Now, if the angiography is normal, then is it possible that option D, arteriovenous malformation, is the reason for the hemorrhage? No, because if AV malformation was the reason, definitely that would have been picked up on the angiography. Not the answer. Now, next one, the patient is on warfarin, so for atrial fibrillation, and his INR was 1.4. What is the likely cause? So he was, he was on warfarin. So could it be due to warfarin? It is possible, right? Warfarin, being an anticoagulant, can produce a lobar bleed. It's possible. But look at the INR. INR is 1.4. What is the normal INR? Approximately around 1. Some people, can put it at a broader range like 0.9 to 1.3 on an average 1. But the value of 1.4 is not very high enough to produce a bleed. Only if the warfarin levels goes above 2.53, then there is a chance of a bleed. But with INR of 1.4, it is unlikely that the warfarin can be the reason for the bleed. So I am going to eliminate this option as well. Okay. Now hypertension, you see, in the history itself, is medical history is notable for well-controlled hypertension. So I am not confident enough to mark hypertension, though hypertension can rarely produce a bleed. Now, remember, in my lectures also, I have told you one important factual MCQ, which is the basis of this clinical scenario question as well. What is that factual MCQ? The most common cause of a lobar bleed in an elderly is cerebral amyloid angiopathy. So when you get an elderly patient with a lobar bleed who is not a hypertensive, think of amyloid angiopathy. And when there is an amyloid angiopathy, always remember amyloid deposition in the blood vessels can also predispose to dementia. So what is going to be the answer here? The answer is going to be option C, cerebral amyloid angiopathy. Perfect, perfect. Very good, very good. Okay, right. So I hope everyone is clear on this. Okay, right. So answer is option C. Which of the following treatments is most appropriate for treating symptomatic intracerebral intracranial hemorrhage that develops within 24 hours of receiving IV recombinant tissue plasminogen activator? So you all very well know that in the management of acute ischemic stroke, you can give recombinant tissue plasminogen activators like Altiplase as well as Tenecteplase. Yes or no? Yes. Now, when you give these agents Altiplase and Tenecteplase, what is the risk? The risk is that these agents can result in bleed. Okay, that's a complication. So suppose if you are having a patient with a stroke and you are thrombolizing the patient with Altiplase, and in the initial 24 hours, suppose if the patient develops any sort of altered sensorium or further neurological deterioration, you should definitely suspect that this patient has gone in for a intracerebral hemorrhage or an intracranial hemorrhage due to the thrombolytic agent. And what will you do? Very important. I have told you in my lectures, immediately stop the thrombolytic agent. That is step number 1. Immediately stop the thrombolytic agent. And then you should follow it up with cryoprecipitate. You have to administer cryoprecipitate as the treatment for a symptomatic intracranial hemorrhage that occurs as a complication of a thrombolytic agent. And coming to the last question of the day, the following image is the diffusion weighted MRI sequence of a patient who was admitted in the neurology department following a stroke. What is the likely finding? Well, this is a previous question asked for the NEET as well a few years back. It's slightly tougher question. Only if somebody has read the topic well, you will be able to answer. Okay, that's why when I have put the questions for these midday quizzes, I usually put some questions which are relatively simple. So around 5 questions will be, 4 to 5 will be relatively very simple. And then a couple of moderate difficulty level and maybe 2 questions or so, which are again slightly more difficult. And I think this is a slightly more difficult question. Now, if you look at this image, you can see that this is the left side, this is the right side. And you can observe that in the left side, there is a hyper intensity. So the diffusion weighted imaging sequence is showing a hyper intensity in 2 regions. One is the region of occipital lobe. So the left occipital lobe, and you can also see this particular region, which is the splenium of the corpus callosum. So it is a combined lesion of the occipital lobe and the splenium of the corpus callosum. And when you get such a sort of a combined lesion, you are likely to get a condition known as pure alexia, which is also known as alexia without agraphia. So alexia without agraphia means he's not able to read. He's able to write, but he's not able to read. That is called a pure alexia. It is not aphasia because you can see the distribution is not, in any of the major language areas. Gaze palsy is not the answer because that happens when there is a lesion involving the frontal eye field and not the occipital lobe. Urinary incontinence can happen only when there is a lesion involving the paracentral lobule. So when you get a combined lesion of the left occipital lobe and the splenium, that is when you get alexia with agraphia. Now remember, it's not just, don't think that this is just a PCA territory stroke. It's not just the occipital lobe that is involved, the splenium of the corpus callosum. You've got this corpus callosal region also being affected. That's why the answer is alexia without agraphia. Now, the mechanism of alexia without agraphia I've explained in detail in my lectures. So you can just go back and revisit the lecture to find out what is the reason why, when there is a combined lesion of the occipital lobe and the splenium of corpus callosum, why do you get such sort of a pure alexia? Okay, right. So that's it. We have had a quick 20-minute discussion of the topic, and you can also follow my Instagram page for any sort of academic updates. I'll be putting a lot of clinical scenario based questions as well in that page. Okay, so you can follow my Instagram page as well, and keep following the DocTutorials app for more such Monday midday quizzes. A lot of exciting prizes to be won. So it's a mix of knowledge, learning, and also some prizes as well. Okay, so hope all of you enjoyed the session. I'm not going for a very detailed MCQ discussion. Okay, that's on purpose. If you have got any queries, you please feel free to ask me in Instagram. You can ask me in my the academic groups as well. Thank you so much for joining. All the best and bye bye, and wait for the next Monday midday. Thank you so much. Bye.